Margaret has been here before and is an excellent speaker. And she is a really good person to tell us about how to better our health. I'd also like to inform you and let you know that Margaret, since we last met her, has had a, would I call it promotion, Margaret? No, well, you've enhanced your sphere of influence, that's what I'll say. And Margaret is now the Vice Chair of the Royal College of General Practitioners. So we are really pleased to have her today. So thank you, Margaret. And before further ado, I will hand over to you. And she's going to talk to us about better health, looking specifically at obesity and cultural factors and risks to our health. Thank you.
Thank you very much, Ngozi, for having me here again. And thank you actually for continuing to do this, because, you know, it's a Saturday morning and I'm just wondering, it took me a while to get myself organized with the kids and everything. I just kind of wondered, how do you find that headspace every Saturday? But thank you. So yes, I'm Margaret. I'm a GP in the Far East, otherwise known as Hull or Kingston upon Hull. I like to make it sound posher than it is. And I've been a GP here for about 10 years, but a GP in Yorkshire really overall for about 15. And I wear lots of different hats, but you know, outside of that, I'm a mum, I'm someone's partner, a daughter, a sister, and, you know, carer really. So yes. So when Charles asked me to do this, I joked with Ngozi beforehand, I think there was a higher power speaking to me, because I do need to address my own weight. And so I thought, well, why not? This is it's been a journey, particularly challenging, I think, if you're anybody, but particularly if you're a woman and when you're entering, I'm not in the menopausal years just yet, but it feels like it's just getting harder and harder to shift. But there's lots of reasons around that, and that I'll come and explain that later. My understanding is this is a really informal session. So if you've got anything you want to ask in terms of a primary care or GP perspective, then I'm always happy to reply. Even if you want to interrupt, I'm happy to take questions. If something's not very clear or I've used language that's too medical, please just remind me. So I'm going to be talking about, I thought I'd start really with our children, because there's lots of evidence to suggest that if you are overweight or obese as a child, that you're at higher risk of becoming obese in adults. And then I'm going to try and address some of the cultural factors that play into that from both sides of the fence really as well. So what is childhood obesity? Now, it's really difficult. I mean, the definition of obesity in general is if you're just carrying too much excess body fat that exceeds your health limits. And it's not just a regional, national, it's a global problem where we have almost 40 million children under the age of 5 who are either overweight and obese. Now, in adults, we use something called the BMI, which is a body mass index. And a lot of you will be familiar with this, but it's difficult to use this in children for a couple of reasons. Mainly, children grow and they get taller and bigger, so you can't use it at all like that. But also, boys are different from girls as well. And also because we know now there's lots of evidence to suggest that if you used BMI in Black children, you will risk overestimating their risk of being overweight or obese. So currently we use something that we call centiles. So what a centile is, and the easiest way to explain it is, say if your child is on what we call this, if the centile's from 0 to 100, if your child's weight is on the, say, 60th centile for her weight or his weight, if you took 100 children of your child's age in ascending order of weight from lightest to heaviest, it means that your daughter will stand in the 60th position, but she weighs less than the person standing in the 61st position, but she weighs more than someone standing in the 49th position, if that makes sense. Now, when my daughter actually, because there's two ways, and you know, specialists argue between themselves as to what overweight means in children, even on the centile. I think there is general agreement that the heavier you are as a child, the greater your risk of things like high blood pressure, diabetes, asthma, or joint pain. the problem with this, I think, is I remember my child, I'll tell you her story. She came home really tearful one day from school. She was about 8 or 9, and the health visitor had measured all the kids in the class, and she was put in the category of being overweight, and she was like, but I'm not, and she wasn't. And she was quite muscular. She does a lot of sports. She's 13 now. She plays county netball, but that stigma that it had on her as a young child was really quite, I think, damaging. It took a lot of reassurance from us as parents to say, look, you're eating really well, you're eating healthily, you're really sporty, there's nothing wrong with you. But we realized that that's not the same for all children, particularly in the last 18 months with the pandemic. It's highlighted the disparity in people who can access quality food. And by that, I mean, the food poverty agenda is really difficult, because if you have a lower income and you have a lower storage capacity to store that food, you're going to choose and opt for foods that are high energy, quite calorific. And you often find that in some areas that are quite deprived, some companies take advantage of that. So you'll find more fast food chains, for example, in those areas. I remember there was a case in Nottingham, I think, a place called Mansfield. It was a few years ago. And I was really impressed because, I've said it now, McDonald's were going to open a fast food chain there. And everyone came together, the councillors, the local populace, and said, we don't want you here. We've got enough problems with obesity here. We don't need it. And actually all the plans to build that fast food chain were rejected. So that was, a real example of power of the people. And obviously with being in lockdown over the last, I know we've come out of it, but people haven't had the capacity to move. I was really humbled a couple of months ago when my son caught COVID, and I had to self-isolate at the time, and we've got, a decent garden, and I sat in the garden moping, and I had a builder doing some work, and he said to me, well, I've in a high-rise flat, Margaret, with 4 children, and, you've got a garden where you can at least run around and get some exercise. And I felt small. I thought, goodness me, this is real for a lot of people. So what are the risks? If you look at the graph on the right, this is from Public Health England. Well, I can't say that now because they've been renamed, haven't they? What were they called now, Ngozi? Is it the Organisation for Health Disparities, or so Health Improvement and Disparities? That's it, OHID. I'm never going to remember that acronym. Oh. So PhD was much easier. So if you look at Black African and Black Caribbean children, you can see, if you look at the pale blue line, those are the age groups of the age 4 to 5, and the darker blue line is the age groups of 10 to 11. But we definitely exceed in terms of numbers, children that are affected by their weight in those age groups. And so we need to really address as communities why this is happening. I can't count the number of campaigns there have been since I've been a GP. And year on year, there's another campaign. It's renamed as something else, but the situation is getting worse. And we really need to get to the crux of why that is happening. On the left are some of the conditions that we are seeing. In practice, actually, the amount of children with type 2 diabetes that I have now is really quite scary. Hull, if you're familiar with it, is quite a deprived coastal city. There's a really good report run by Chris Whitty on coastal deprivation. It's worth a read, and Hull features in that quite strongly. And we are seeing a lot of problems with children and with adult type diseases, which is really quite upsetting. So Royal College of Physicians, is their president, called Professor Goddard, says obesity is not a lifestyle choice caused by individual greed, but a disease caused by health inequalities, genetic influences, and social factors. And there's still lots of research that needs to be done into this, and there seems to be something new every few months that we never knew before. We know now that genetics, despite some people still saying, well, genetics doesn't play a part, it really does. There are some rare disorders that children can get, but they are rare and they affect perhaps a single gene. And then there are other more common disorders that we know that people can be familiar with, that can affect the way they carry adipose fat tissue. We know behaviours are really, really important. And by that, I mean, I see in my office where, you know, if a parent wants to placate a child because they're making so much noise, the common response is shoving a lolly in the child's mouth, which is not often the best thing to do, because you're using sugar to satisfy a negative behaviour. And we know now that the number one reason for children in certain age groups going under general anaesthetic is because of dental problems. So we do know that having good parental role modelling does help child behaviours, although it's difficult because we used to have health visitors occupy a room in the surgery, but about 3-4 years ago, a lot of childcare centres in our area were underfunded and had to close. And then all of a sudden, the health visitor wasn't able to come to the surgery anymore because of some political agenda. So I find it really difficult when the government's trying to tell us what to do, but on the other hand, I'm trying not to be too political here, they are withdrawing the services that actually help to support families in terms of what does a good diet even mean? Because unfortunately, a lot of the families that I deal with don't have the same family support structures that maybe some of us had when we were growing up. And then, you know, it's much easier to get a takeout every day. I don't know if you saw this program. I watched, I shouldn't confess to this, but I do watch Gogglebox quite a bit. And there was an episode with Kerry Katona. And what was shocking was she submitted, I mean, I know she's completely different in terms of wealth scale, but they never cook. They live on takeout food. But she's not alone in that. A lot of the people I deal with, cooking is just an alien concept. It's all about takeaways, and so that's not great. Psychological issues we know are really important. We know that children who perhaps overeat may be doing it for other reasons, so it's always important to explore that. From a cultural perspective, I sometimes find it's sometimes difficult, and guys, I don't know as a paediatrician if you feel this, that when you want to probe a bit further, if you are entering into territory which is quite delicate, the caregiver will automatically shut down, and it's really hard, I find, to engage, because sometimes we don't like talking about things like, I'll be quite frank, things like child abuse that may have happened previously for whatever reason. There's certain taboo topics that I find, I had a patient who her daughter was having treatment for urinary incontinence in abroad, and that was a red flag for us. Like, why are you going to Poland to do this? And we had to alert safeguarding, but she was morbidly obese as well. But God, I don't know if you found that culturally it's difficult to address.
It's really difficult because it's almost, because you're speaking to the primary caregiver, there's an element of, even though you say, look, this is no blame, we're just trying to explore the issues, it automatically feels as if you are ascribing a certain amount of responsibility on the caregiver. So it's really difficult. And I know what you mean about the takeaways. Sometimes when I talk about cooking to parents, cooking to them is buying not a takeaway, because a takeaway is when you just order a fresh takeaway, but buying a pre-made meal from the shops and putting it in the microwave, that's how they cooked that night.
Yes, but it's how you get that message through that, and sometimes it's hard because sometimes to cook is actually slightly more expensive. It's easier and cheaper to get the highly processed stuff, and it's a really difficult thing to do. And quicker, yeah, absolutely. Can you imagine, you've gone to work, you've come back, the kids are hungry, I get the odd takeaway for the kids because it's just easier to deal with, because and especially if you've got an evening meeting that you have to go to, and because work hasn't stopped, so I'm making excuses here, but it's difficult to incorporate all this into real life.
I think it's important that someone like you who's giving this talk can actually identify, because very often when you hear people talk about this, it's almost as if they're on a pedestal somewhere, talking down to everybody, saying this is what you must do, thou shalt do this, when they haven't actually taken into account everyday living.
Yeah.
And now with online meetings, it's very easy for that to just filter into your evening, and the time for making meals that are nutritious, time, with very timely and take up a lot of time is being squeezed.
Yeah, it is. So I think these are all things to consider. What you mentioned was the stigma as well. I mean, there's lots of evidence, particularly from the educational sector, that teachers will discriminate, really, children who are overweight, and they have lesser or poorer outcomes in terms of educational attainment because of their weight. And we know that happens. We know it happens in the work environment as well. So there's lots of evidence around that. And we know that healthcare professionals, even at the surgery where I work, there's some horrendous stories where, women will talk of being asked to lie on the floor to have their smear because the nurses said, I'm sorry, you're going to break the couch, or something horrendous. Or, if someone wants to measure someone's blood pressure, they're running around screaming, I need a large BP cuff, please. Like, why do you have to announce it? Imagine how that person sitting in the chair feels. Or, and these are real stories. Or the gentleman a few months ago who actually got stuck in the chair because we didn't provide chairs that had no arms. And so we had to think, like, okay, we need to get some chairs in. So it's these kind of things that we really do need to start thinking about. Okay, so let me go into the next slide. And there's obviously the environmental issues as well, which come into play. So I've talked about the lack of space, the fast food chains, and just higher levels of household stress. Because you can imagine if you've got a number of children, you're in a demanding job, stress itself, we know, leads to increases in a hormone called cortisol. And we know that, if you've got higher levels of that floating around in your body, you're more likely to gain weight. So let me see if I get right. So coming to the management of children, I found this again on the, I'll keep saying PHE for now until I remember the acronym of the other one, on how we can deal with this. So for children, in all honesty, there are some drugs that are available, the same sort of drugs we use in adults, but as GPs, we can't prescribe them unless we have specialist input. So we would have to refer children who we feel are quite overweight. So I should have said overweight means anywhere above that 85th centile. So if you remember this bell curve, so my son's now distracting me, so I'm just going to do a wave. I've not seen him for 2 days. So I've just, at the bell curve here, anywhere towards the right-hand side, above 85%, that shaded area, you're at risk, and above 90%, you're at risk of being obese. So sorry, I'm just going back here, I should have said that. The challenge that we have are, again, lack of services and where to send children to, and it's geographical. You may have a fantastic service in Manchester. That's something I needed to look into, but you'll find that in Liverpool or perhaps Leeds, that they won't have the same kind of access. So there's quite a disparity in what's on offer. Now we've got something or a group of healthcare professionals that we call social prescribers, and they have been quite innovative, I think, in the practice, because they often have better engagement with the services that are out there, because often we can't know everything. And so we often use our social prescribing team to help us. But we're mindful of what we call the COVID effect. Children have missed a lot of school time in the last year. And, we talked about the lack of physical activity. I know there's lots of schemes now to help put stuff up in parks and things, but the after school clubs is the other thing that we have a lack of in this area. And I imagine regionally, they aren't as plentiful as they were when I was growing up. I remember going for summer schools to just a free club in my local area in South London for the whole summer, and it was just great. We went on trips to Margate and Brighton. We were always doing something. Now, most places you have to pay, and it's a daily rate, which is quite expensive, and it's hard. I don't see the availability of these clubs as much as we used to. So I'm just going to quickly come to the adults. There's not much in terms of difference, but we do use at the moment body mass index, which is your height in centimeters. So start again, your weight in kilograms divided by your height in centimeters squared. And we've got an agency called NICE, which is the National Institute of Clinical Excellence. And they say if you're between 18.5 to 24.9, when you do that calculation, that you are in the healthy weight range. However, we realize again that this is not a perfect model, that we have to use other forms of evidence, because we know that some people are more muscular. You know, if you took a gymnast or a rugby player, they're going to have a much higher BMI than the average individual. So this would not count. And so we also use waist circumference as a measurement as well. Again, there's things that we can do. And I was showing this to my mum. I've just noticed your mum Ngozi. So hi, Ngozi's mum, sorry. And I was asking her about things that she felt we could implement in the family, because we had an aunt of mine who was really, really obese. I mean, we were really worried about her weight. And she was prescribed the drug called Orlistat. So that's one of the drugs that we can prescribe. And what Orlistat does, it reduces the amount of fat absorption in your stomach. And she did amazingly well. She went from like a size 26 to a size 14. She looked amazing. And she felt better, she moved better, she had less joint pain. But then her church group members then started to say, you don't look very well. You've lost so much weight. This doesn't suit you. You know, you look better when you're weightier. Because she was single, you won't find a man if you're this skinny. You know, it went on and on and on. And then she regained it all, because she felt that she was almost being ostracized by her community. And it was such a sad thing to do. And so how do we as a community try and reinforce positive messages that people, you know, where there's cultural norms that they've brought with them, or believe that a weightier person is richer in terms of their experience in life? I don't have the answers to that. I'm just curious. A couple of weekends ago, we went to a party, and I don't know if you've watched this thing called Famalam. Clearly, I watch a lot of TV, and there's a sketch where they have the aunties, I think they're from Nigeria, with their takeaway boxes in the bags, and there's a battle to get to, you know, everyone's eyeing up the food at the end. And my mum, we're not immune from this. And every time she does it, it's like, oh my goodness, like, do you have to take food home? You have this food at home. But not only that, I think in certain cultures, we value the quality of a party or an event. It's based on how good the food was. So I can imagine my own wedding, when people coming around to say, you know, congratulations, well done. One of our aunties said, good wedding, but the food. So I was like, my husband just said, did you come to see us get married, or did you just come to eat? You know, or my friend last week, where we went somewhere and there was so many delicacies there, and she just put every single thing on her plate. And I said, is there a famine at home? Like, what's happening here? You know, you don't have to, you're not going to miss out if you don't have the samosas and the pizza over there. So how do we, and her response was like, well, we're out of lockdown. This is my first party. I have to, I've been depriving myself for so long. And so it's really quite difficult, and we don't get it right all the time, but I think it's just about promoting these healthier options to people that can help. So there are a couple of factors in what I've already described for the children, but one of the interesting ones is maternal factors. So when Charles asked me to do this, I've obviously been reading a little bit more about it. I think even when you're in the womb of your mother, what your mother eats apparently determines your outcomes as well, in terms of how much weight you can gain. So an expectant mother who's about to have a baby, who is more likely to, if she's overweight, the outcome of her child being overweight is much, much higher. And I found that quite interesting, but it wasn't just the mother. So I put maternal factors. Apparently there are paternal factors as well. If both parents are overweight, then the child is much more predisposed to being obese as well. And there are behavioral factors as well. And one of the things that I was thinking of is people who do shift work. So I have a number of patients who struggle because their body clocks have come completely upside down, and they'll be having a normal meal at 3 o'clock in the morning when they're at work. But what do they do when they come home? They sleep. So you've got that imbalance of the less activity because you're just coming home, you're eating whilst you're at work. If you can think of the scenario perhaps that we had with, and again, I'm coming back to COVID, bus drivers in London, the large majority of bus drivers in London that died were of Black, Asian, or minority ethnic background, and they were overweight, as most people in ICU were overweight. So it's looking at those behavioural factors as well. So I've talked about the stigma. I think it's really important that we, particularly as healthcare professionals, because it's not just GPs, I've sent people to a dietitian and had people come back in tears saying that they just felt vilified and that they're never ever going to see a healthcare professional again. And it's really difficult to bring this up in a consultation because there are a number of doctors, GPs included, who will always, if someone comes in with knee pain and they're overweight, well, guess what's going to happen? The doctor's going to talk to you about your weight. And it's almost like with anything they can find, they'll try and find a way to talk about your weight. But there's ways as healthcare professionals, we can do that. I often say to people, right, okay, I don't want to state the obvious because we all have problems, but if there's ever a time you want to discuss your weight, then I'm here. So I'm not asking them, I'm just saying, look, I'm here. And 9 times out of 10, they'll say, well, actually, now that you mentioned it, and then we'll have a discussion. So that's something that we need to also consider. We have what we call a tier system in the UK. So primary care, if you are overweight or obese, there are 4 levels that we can refer you to. So usually level 1 is stuff like community-based stuff. We are told, ideally, we shouldn't as GPs be discussing the type of diets for patients, that we should be referring people to a dietitian. But I don't, for me, it's a guideline, it's not a must do. Some people do not want to engage a dietitian because of a negative experience like I've described. So I'll tell people, okay, do you know what? Let's do a food diary. Just write down everything you do for a few weeks. And just like everything, you can either write it down or there's loads of apps that you can use. We don't set any targets, just let's see what's going in. Let's just do that. And then when they come back, we'll have a look at it. And then you can just make a small change. You can say, well, do you know what? You've only had 1 glass of water like every day or week. Why not just up it till 6? Try, it's hard, it's a tall order, but just try and drink, or before, every time you eat, just have a glass of water. So just making a really small change. Because if you tell someone, oh, do you know what, your BMI is 40, you weigh about 18 stone, we need to get you down to 12 stone or 11 and a half, it's just mind-blowing for some people. It just feels like it's a challenge too much. So I always often believe in just small adjustments. I think we can do that in primary care, or use our social prescribers that I've just described before. We've then got tier 2, who there are lots of commercial weight loss programs out there at the moment that are being commissioned by our local commissioners. So about a year ago, we were approached by a company called Oviva, and there's many out there, and I have no affiliation with them. And they have some Nestle products, and they're called very low calorie diets. So when I say very low, usually we would aim for about 1,500 to 2,000 calories, depending on your activity levels. These diets are 800 calories a day, and they're usually comprised of things like just shakes that they have. So they get powders and they mix them up. And they were targeting them at people with type 2 diabetes who aren't on insulin, because we know now that people with type 2 diabetes who are overweight, we can reverse their diabetes through weight loss alone. And that's been profound, and there's lots of evidence out there. But unfortunately, at the time, the program was piloted during lockdown. So we had some patients who actually embraced it because it was something different, something to do. And there's one couple that I had when I rang them up to find out how they were getting on. And I said, there's a lot of background noise, and they were quiet. And I said, where are you? And they said, we're in McDonald's. I said, well, what's happening? They said, look, Dr. Ikpoh, it's lockdown. We are, and it's the first time McDonald's has opened. There's only so much we can, you know, shake every day, morning breakfast. This is just depressing, you know. So I think we have to be mindful of what people want as well. Tier 3 is when you refer them perhaps for investigation if there's something else going on. So usually a specialist weight management service in the community. And then tier 4 is when you refer them for something called bariatric surgery. So this bariatric surgery essentially is surgery that's designed to reduce the capacity of one's stomach. And there's various ways they can do that. I remember working for a bariatric surgeon like 10 years ago, and I was quite upset one day because a few years ago in Leeds, I was stopping at a petrol station and I saw him and I waved, and he ran up to me and said, "Oh my gosh, you look amazing. You look amazing." I'm thinking, it's a really inappropriate way to be talking to your former SHO, but you know, and then it's only when I got into the car that I realized he must have thought I was one of his bariatric patients. So I just thought I'd tell that story because I found it my husband found it quite funny. So yes, and again, it's not always easy to get people to that tier 4 because it depends on where you are in the country, which again is unfortunate. And I'm hoping that we can align our services with each other. So there's lots and lots of benefits of managing obesity. We know that even reducing your weight by 5% will improve your blood pressure, your sugar control, even your fertility. The amount of women that I see sometimes who are struggling to get pregnant, and it's a really hard discussion rather, when you say, well, have you thought about your weight and how it could help? And you know, I said, well, let's just try. You've tried everything else. And honestly, with just a 5% weight loss, they're coming back to tell me, oh, guess what? I'm pregnant. So we shouldn't underestimate that at all. I'm seeing lots more people with sleep apnea, so trouble breathing whilst they're sleeping, infections of the liver, moving, and problems with their waterworks. And also we know that if you manage obesity well, it will reduce your cancer risk of certain cancers especially. But again, we need to be really realistic with this as well, and take an individualized approach is what I call it. So physical activity, I have people who tell me, look, I don't have time to join a gym. I don't have money to join a gym. And I say, well, you know, I can completely understand that, but you can just walk around the block. You know, you can do something. But the idea is if you can do at least 30 minutes, 5 times a day, sorry, not 5 times a day, 5 times a week. But you can actually just do, if you're keen, you can just do, you know, you can do that, condense it into 3 days if you want to. There's lots of clubs out there, I'm finding. There's one that I've joined recently, but I'm waiting for them to come up north, called Black Women Who Hike. They're on Instagram, and it just looks like a phenomenal community, and I'm really looking forward to doing that. But there's nothing wrong with, I think one of the most powerful things that have worked for me is just finding a couple of friends. So I have a WhatsApp group with a couple of my girlfriends, and we plan our walks, we plan some bike rides as well, we plan activities with the children, we share some really healthy diets as well. There's one, I'll come to it in a minute. Oh, let me just have a look. There's one diet here called Heart UK. So if you go to this website, if you just Google Heart UK, they have, because the challenge I find with a lot of diets is, particularly African and Caribbean diets, when you go to the shops, there's no calories on a lot of the products that we buy. So it's difficult to know what's good for you and what's not. But what these guys have done, they've looked at specific diets from specific countries, and they have some plans on there. They have some healthier options, but I'll maybe skip that. I'll come back to that in a minute. So like I mentioned, we have medication. We've got Orlistat. That's the only medication that we can prescribe. And if we prescribe it after 3 months, apologies for the typos on this slide, after 3 months, you have to have lost at least 5% of your body weight for us to continue prescribing it. So that's what my aunt had it for about a year, and it worked really well for her, unfortunately, until her group got involved. And then we've got liraglutide, which is another weight loss drug, but this can only be prescribed by the hospital, really, and on that tier 3 level that I described earlier. And then, of course, we've got bariatric surgery. And actually, bariatric surgery is the hands down most effective form of weight loss, just because it is. but what we need to remember, because a lot of GPs forget that because you were reducing the capacity of your stomach, we're also reducing the capacity of your stomach to absorb certain nutrients. So after 2 years of having bariatric surgery, we do need to check your vitamins and your iron levels just to make sure that you're not deficient in any of those. So I've touched on some of the cultural issues with the perception of weight with ourselves and how other people see us culturally. Food labeling, I think, is a huge issue. I've got a friend who owns an African food store in Hull, and I said to her, well, what do we do? Because some places it's good. I thought there was supposed to be some food standards agency that's supposed to make sure that these things were labeled, but it doesn't always happen. And then I think what's really lacking, I think, in certain places are how healthcare professionals approach this from a cultural angle, because GPs or healthcare professionals are, at the moment, you'd have seen the press on, can't see my GP face to face, and there's all this GP bashing going on. It's almost like, to discuss someone's weight is just another barrier when you feel that they don't really want to discuss it. So then it just gets left, and which I don't think is a good thing. So, we need to be having more open discussions about this, and actually how we can, like Ngozi says, rather than just telling someone to go off and do something, actually that's not ideal. Because there's certain resources that we need to be looking into to make sure that we are including everybody in the conversation. I did a menopause workshop 3 weeks ago, and I didn't know that Black women go into the menopause a lot sooner than white women. There's a big study that's come out in America called the SWAN study. So why is that important? Well, it's important for several reasons, because if we're going into the menopause slightly earlier, so on average it's 2 to 3 years earlier, because your hormone estrogen comes down, you get less protection from your bones and less protection on your heart system. And so if you add, and also you're more predisposed to getting abdominal type central obesity as well. So if we're not tackling this at a much earlier stage in a woman's life cycle, then we really are missing out on something. You might be familiar with SMART goals. So be specific about what you want to do. So for instance, I use the glass of water analogy. Let's try and drink 6 glasses, because you can measure that. That's the M. It's achievable, we hope. It's realistic. And we've got a target there with the T. So that's something to consider. And there's loads of apps out there, and I find them all so confusing. But the one that I do use, and again, I have no commercial affiliation, it's the blue one on the top in the middle, the Myfitness app. It's quite a useful one, and it's free. But at the end of the day, like some of my patients, they just use pen and paper. It doesn't need to be a high-flying, all singing and dancing thing. We need to look at, and this is from the website I was talking about, just the way we cook our food. I'm looking for an air fryer for Christmas. So if anyone wants to buy me an air fryer for Christmas, then please, you're welcome. Because I've heard that it's much, I don't know if anyone in the group has one, it's a much easier way and healthier way to deal with our foods. So we look at what we call foods with low GI, which is what we call a glycemic index. So the foods on the left have a high glycemic index. So for example, as soon as you eat them, your sugar levels go up really high, but come down very quickly. And so that after a couple of hours, you're still hungry and you want to have more. Whereas the foods on the right-hand side have a lower glycemic index, so slightly lower sugar index, but they are more fulfilling and you feel fuller for longer. So, yeah. And then this is the last campaign that I'm aware of from PHE. Now, I again, it's open up for conversation. I think they're important to keep doing these campaigns, but how effective have they been? That's what we need to know, because we know that we are getting bigger as a nation. So where are we going wrong? What is it that it's not working? And some of the things I've already alluded to already. So as a GP, we can definitely discuss this for you. We can definitely prescribe this for you if you meet certain indicators. And then we can definitely refer you on to other people to have a discussion if needs be. And I think, goodness, I can talk for England. That's me. That's me done.
Oh, thank you very much, Margaret. That was amazing. That was really interesting. And it was really helpful. I think we've got lots of questions. I'm going to go to them soon. That you started off from in pregnancy, the things you can do. And one of the things as a pediatrician I'd want to add there is about breastfeeding. So I always take the opportunity to tell all my mums about the value of breastfeeding, because that's also quite protective. I know I have mums that says, well, it doesn't fill them up. And sometimes I go and visit and you can tell when they've had a bottle of feed and they're there really, really zonked because of the calories that you've managed to get into them so that they sleep throughout the night. But in actual fact, breastfeeding is the best milk for babies. So I'll make sure I get a plug in for that as well.
Yeah, thank you for that.
Thank you so much. Thank you. So as usual, there are lots of questions, and I'm going to start off by the one about menopause, because you talked about that, and there are quite a number of questions about menopause. So one of them here is talking about the somebody who's got menopause. They're really anxious about putting on extra weight during the menopause, and has refused to take medication because they read on the label that one of the side effects of medication was weight gain. So they've got a double-edged mammy, and they're just asking about what advice you would give for that.
It's a really good question, because it does cause weight gain, or can cause weight gain. I think you have to, like with any medication that we prescribe, you have to look at the risks versus the benefits. So by that, I mean, if your menopause is such that it's interrupting your normal activities of daily living. So you're not sleeping well because you're waking up with night sweats, your work, you're having to have the windows open, you can't concentrate, and the HRT that you've been prescribed at a low dose, because the lower the dose of the HRT, the less likely you are going to have the side effect. But if at a low dose, your quality of life is significantly improved, but you gain a pound, so I'm just being sort of theoretical, that might be a good trade-off for you. However, if you gained 2 stone or a stone, that would be unacceptable for most people. We think, do you know what, I maybe just have to look at an alternative to HRT, because it's not, there are alternatives to HRT hormonal treatment if needs be. So it depends on what you're happy as an individual to accept as a trade-off. And I think that's really, really important. There was something that I perhaps should have mentioned earlier, which was something called a metabolic set theory as one of the causes for obesity. I realized I didn't talk about that, which basically means that as we get older, your body basically sets your metabolism at such a point that, okay, anything below that point, you're going to be able to lose weight, but it sets it quite high. And that's why women who have successive children, sometimes it keeps getting reset. So when you're trying to lose weight, your body will do everything in its power to fight you with it, because it likes your metabolic set to be at a certain point. So and that's why you always have people that come and say, I don't understand what's happening. I'm eating the same food as I did when I was in my 20s, but I'm now gaining weight. And it's really around this metabolic set theory. I don't know if I've explained that properly, but it's a real big challenge. And so I often tell people, yeah, I completely get that, but it's the way your body's now reacting. Our bodies don't stay the same. They will react with time and they will change. So it's going to get harder. So you have to, whatever you were doing before, it's not going to work now. You have to do something completely differently. So with the HRT, it may be with your diet or your activity levels or whatever, you're going to have to do something completely differently than you did before.
Like maybe exercise a bit more. And you talked about Black Girls Hike. I've been on one of their hikes. It was amazing.
Are they good?
They're really, really good.
I'm
They're
glad
really
you said
good.
that. Yeah. Okay.
Yeah. So I did one about a couple of months ago.
Okay.
They happen at the weekend, so either Saturday or Sunday.
Right. It's on my to-do list then, even more now. It's just moved higher up.
So another question here about the waist circumference.
Yes.
So there's somebody here who says that they're quite slim, but they've got quite a big tummy.
Right.
And so when they do that measurement, it puts them down as being obese.
That's why we need to take an individualized approach, because I know I've got slim friends who may have fibroids, for example, and they're not causing them any bother, but what it does is they have a slightly protruding stomach. I have friends who have who've not been able to get the same abdomen back that they had pre-pregnancy because of a separation of their muscles in their stomach. So it's just about, you know, if that's the situation, just because a chart tells you it's a bit, and you know yourself you're slim, then I would just ignore it, to be honest with you.
Absolutely. Yeah. It's like the when you're talking about childhood and the centiles that we use in children. So I've got children and my niece and nephews were actually quite big and big for our age. And so my niece is probably at the 97th centile, but she's really tall. Yes. So everything she measures on the 97th centile, but she's definitely not overweight. She's just quite big for her age. Yeah. And that's the difficulty with the interpretation of that. So I always say to parents, you've got to take everything else into account: how big your parents are, how tall you are. Yeah. And so it's lots of different things. So the question here about, do we feel that there's any way that parents can influence schools to provide sort of basic parenting courses about nutrition?
I think that's a good question. I think if you're part of, even if you're not part of the committee, I would ask. I don't know if you remember, but I remember having cookery classes when I was growing up. And I'm not sure, like my daughter doesn't have any such classes at all. There's no, you know, I'm not wanting her to be a homemaker, don't get me wrong, but I think there should be some basic skills that they have. But it just seems to have disappeared from the curriculum in such a big way. And I think you're right, they spend most of their lives, don't they, in schools? And I think this is where things need to happen. And perhaps now that that question is asked, it's something that I think I really want to explore in my spheres of influence that you mentioned before, as to what we can do to try and influence that. So I would ask the teachers, you know, you have your PHE, it's the same with the menopause. My daughter asked me the other day, what's menopause? And I said, well, it's not on the curriculum. And when you think that 15 million women are, you know, spend their life cycle in the menopause at any given time, they'll talk about other things, but you can understand why there's a lack of knowledge later on, because it's not taught in schools. So that's a really, really good, valid question.
Yeah, thank you. Because I think there's a captive audience as well, you know, because I feel that, again, with our sphere of influence as parents, you remember when you start off with your children and you are the, you know, your word is final, and they put you on a pedestal, and very soon that moves to school, where the teachers become their sphere of influence. So these are captive, and this is a time where they should be trying to influence them about all kinds of life choices, including what you do with your diet. The other thing that someone's asked here about, any thoughts about intermittent fasting?
So I apologize for any background noise. We've just had a massive storm outside. Intermittent fasting is great if you can stick to it. So I'll give you two examples. My dad, but he fasts for religious reasons twice a week. He's done that for the last 20 years. And like 2 days a week, he just has some brown bread and water, and he's kept his weight off perfectly. There was a chap called Dr. Michael Mosley, who you might be aware of, he's a media GP, and he is a real champion for this intermittent fasting, and he came out with something called the 5-2 diet. And I think a group of us at work, we all did it, and literally for 2 days a week, I think you restrict your calories to about 800 calories a day, just for 2 days. You could pick any 2 days in the week, and there was significant weight loss in the group, but it needs to be something that's sustainable, and that's the challenge with intermittent fasting. But I know people who do it lifelong. There's also something called there's lots of types of different intermittent fasting. You can do it based on your hours. You know, some people do it for 16 hours and just, you know, fast for 16 and just have an 8-hour window or a shorter window. And time again, the results show that it does work, but it's whether or not and people use it as a catalyst, because people say, well, you can't keep doing it for life. I said, well, no, you can't. But if you have a significant amount of weight to shift, there's no harm in doing it for 6 to 8 weeks to help you. You know, someone mentioned about medication being the last option in the chat group. But for some people, you're caught in a bind, because if you're so big and you're telling someone that you need to get more active, it's hard, because you're in a bit in a vicious circle. Because if you've got arthritis or you're in pain because of your weight, how are they going to start moving? Whereas the medication as an option, because it is an option, or the intermittent fasting helps to get that initial weight off so that they can get moving. And so there is some positive benefit.
I guess one of the things that I remember watching him, one of the things he said is that what they find is that even when, because I think sometimes they have the 5-2 days, even when you're on the days that you can eat as much as you want, people tend not to, because they think, well, I've just fasted yesterday, I'm going to undo all that good. So there's some psychology to it that means that even on the days that you can eat whatever you like, and people tend not to just go overboard, because they think, oh, I've just spent yesterday fasting, I'm not going to undo it all.
Exactly.
So it becomes quite useful. There's a question here about fibroids. Is the fibroid question related to your problems you might be having with weight? Maybe you can just put a clarification comment in the chat, if that's okay. And I see your comment.
She's put no. Yeah, it's an interesting question though. There's but I stand here not as an expert on fibroids, but a couple of years ago I was at a dinner, and it was I think it was Mansag actually, so it was something to that, and there was a woman next to me who went to the toilet. She was there, and she was feeling very unwell, and I asked if she was okay. She said, yeah, I've just eaten the wrong thing and it's affected my fibroids. And I was like, how's your diet affected your fibroids? I was like, really? And so but since then I've had 2 friends. One's a consultant orthopedic surgeon, and she will swear that her change in diet, I mean, maybe this is a whole nother webinar, I don't know, because she was due a hysterectomy as well, and she wants to have kids, has significantly improved her outcome with the pain from her fibroids, but she is on a really restrictive diet, no sugar. It's, when she comes around, I dread it, but she brings her own food because I can't cook for her because it's so restrictive. But, oh, Faye, that's interesting. So I'll log into that. Faye just put there's a session next week on Black women and fibroids. So I definitely want to be tapping into that, because I don't know the evidence base around this, but the medics that I know that have altered their diets who have had fibroids swear down that it's helped them. But it's anecdotal because it's only 2 people. But I'll have to have a look into that in more detail.
Yeah, because I suppose at the end of the day, many people tend to I always say we're experts on their own bodies, in a sense, because what makes you feel right. And what these sessions, one of the benefits I see of these sessions is for you to have a real sort of ownership, but you can have a dialogue with your health professionals instead of that sort of paternalistic view. You can help to inform them so you get the best out of many of your consultations.
Yeah.
And I think that's what people have said, that when they've gone to these sessions, they think to myself, I can go and speak to someone. And I think it's really helpful. We'll have a fibroid session next week, because nobody can really push you to have a hysterectomy. They can give you lots of advice, but they cannot insist that that's the only treatment you can have.
Absolutely.
They just will offer you the different options.
Mm.
The thing you talked about, these shakes.
Yes.
Yeah. So I remember once where the shakes, they can't be that nutritious. Just, is it when you have the shakes to the exclusion of everything else?
So you can only stick to these shakes. It's almost like I don't know if you've seen Slim Fast. It's
Slim
probably
Fast,
similar,
yeah, I remember
something like that. Yeah. So, and I just think you can probably do it for 3 or 4 days, but to stick, because you have to. I think it's 8 to 12 weeks they're on this shake plan. But we've seen such drastic change in people who've been able to do it. It depends what your drivers are. I just think it's a hard thing to do. I think really just trying to address the smaller changes in life will be better for the majority. But saying that again, depends where you are in terms of your health risks. If you've had a heart attack and you've been told that unless you get this weight off, you're not going to be around, I will be taking those shakes, because I want to see my children grow. So it depends on what your personal drivers are. So the shakes, it's if you go to your GP, there is a national prevention program for weight, to control your weight. So your GP should be able to tell you that. It's different in every area because there's a different provider depending on which, what we call them CCGs, clinical commissioning groups, which are going to evaporate soon, but depending on the agency that controls healthcare in your area. But your GP will definitely be able to signpost you to a number of programs actually now. There's a number of dietary programs that are available now that your GP can prescribe, can signpost you to, which have worked well.
Just the one about shakes. I remember someone once who thought that the shakes were actually had some sort of melting ability. So continue to eat what they wanted, but sort of topped up with the shakes.
Oh no!
I couldn't understand why they weren't losing weight.
Oh dear, no, that's not going to work.
No,
oh,
that's not going to work. They thought Synflast, they thought it must be something in it. That sort of,
okay, I see where you're, yes,
yeah.
Yes, okay.
So that's what information and right communication is key, isn't it?
Absolutely.
Yeah.
And checking in, you know, often you give someone, I will call my patients, particularly on Orlistat, the tablet, because that can have some really nasty side effects. One of them, and embarrassing for people, you know, they have oily, call them oily farts, oily flatulence, which is really not good for some people and they can't tolerate it. So I will check in after about 3 to 4 weeks just to make sure how they're getting on, really.
Yeah, no, I had a friend on that and she said her children always knew when she was on it and say, Mum, you're on the fat medicine again because it just stinks here. So she gave it up in the end.
Oh dear.
Yeah, but I think the message here is that for anybody who has dialed into this when they saw the topic and think that I'm really struggling, it's not insurmountable, even if there are tiny changes you can make.
Yeah,
and the journey starts with the first step. And you may have heard this lots and lots of times and think, well, you know, my body makeup is different to other people's, and that may be so. But there will be something that works for you.
Yeah.
You know, when you were talking about the bariatric surgery, is there a cutoff? Because you have these different tiers of service that you'd be referred to that. Who decides that? Is that the GP, the patient?
No, it's your BMI. So once your BMI hits 40, and you're classed as severely obese, then you're eligible for bariatric surgery, or should be. I say should because, again, that's what NHS England have suggested. And in my area, it's amazing. I'm in Hull, but Hull we have 2 CCGs. And so I'm in an area called East Riding. So for East Riding, I can't, if someone has a BMI of 40 and above, I have to have a conversation with someone first about whether they can fund that individual. Whereas if you're in Hull, you can just be referred directly into the service. So it's bizarre, but it's unfortunately what's happening.
The real postcode lottery, as they say.
It is, yeah.
Do you think the development of the ICSs will make that any better?
I think it will, because for us, it's going to be, hopefully, fingers crossed, a better integrated system where we will have members from our local communities, voluntary sectors on board. You know, I had a community group last week and they said something really quite profound. They want to meet because they've been tired of being told, you know, how they should access the service, you know, because the way they perceive it, and it's true, we're always giving them an instruction, do this, do that, do this. Nobody's asked them, you know, what's best for you, what works for you. So I think having people on board from different spheres of different areas will be profound in the way ICSs will run. But you know, Ngozi, it's all going to come down to the people at the top and how well they lead that implementation. And if they are really truly being genuinely inclusive, that's what's going to make the change.
And just for people who are logging onto this, an ICS is an integrated care system, and it's a different way in which they're going to commission health services for each area in England, and that's coming soon. I think if you are subscribed to the Caribbean African Health Network newsletters, there was a call for you to volunteer services to be part of these ICSs as one of the voluntary sector, and also apply for positions on it, because if you're not involved and you're not involved in this, you won't be able to influence the way health service shapes up in different areas. So it's incumbent on us that if you can to sign up. Okay, I'll just check that there aren't any more questions in the chat, and I've had some private messages to me which I've discussed with you. But once again, thank you, and may your sphere continue to to expand, Margaret. We're really proud of you.
Oh, thank you, Ngozi, and thank you,
As
CAHN.
Vice Chair for Professional Development and Standards of the Royal College of General Practitioners.
Thank you so much, and thank you for your support, guys. Much appreciated.
Okay. I'm just going to hand over to Charles. Charles, would you like to have the last word? And if he's I know he's here because I saw him in comment, but he's always multitasking. So who knows? But anyway, it's the hello? No, okay. But anyway, I think he might be multitasking as usual. But I'd just like to say thank you on behalf of the